All right, let's make sure everything looks and sounds good, and then we will get going. Okay. Let's take a look. Pat. Well, that's fun. I'll be right back. Excuse me. Let me see here. How do we sound? All right, sounding good. I think we're sounding okay. Let me just go plug something in. All right. I think we are good to go. Let me just share this real quick on YouTube. Had a quick cat interruption because of some playing around. So, just share this real quick. All right. Oh, God. I think we are good to go. Let me just share this real quick. Jesus. Sorry. There's these pop up on YouTube real quick. My apologies. I just want to share this on Twitter, and then we'll get going. So very sorry for the delay. Got it. Why can't I click got it? Oh, boy. I don't know why. This is going to get very frustrating very quickly. Okay, what the hell is happening here? There we go. Now we can share it. Thank God. So very sorry for the delay. Here we go. Just going to share, and then we're going to get going. Okay, I think we done it, and I think we're there. I think everything is okay. So without further delay, here we are. So sorry for the delay. Technology will never catch on, Patrick. I know, it's absurd. Reminders, pop-ups, so on and so forth. So, happy Saturday. Good afternoon, everyone who is watching and listening. Thank you for being here. This is UnShrink Me, and welcome to a weekly podcast focused on mental health, psychology, psychiatry, etc., etc. Anything that we can talk about to perhaps improve the lives of people using their mind and their behavior. So this is a weekly podcast on YouTube on my psychology checkup channel, and it's called UnShrink Me. Welcome to being here. And I am Dr. Patrick Lockwood, even though technically I'm just Patrick, so don't sue me, but feel free to cancel me, which are different. So this is not psychiatric advice. This is not clinical psychology advice. This is not advice to you as individuals. This is a weekly podcast where I discuss popular topics that are trending typically on Twitter and other places. And we talk about what is realistic about those topics. If the hot takes are a little too hot, not hot enough, so on and so forth, I give my spin. People in the chat, often clinicians, give their spin. So it's an awesome experience, and I'm really grateful to be here today with you. We have one really big topic today, which is why therapy doesn't work, which is going to be a little more scandalous than I think even the title seems, but we'll see. And we have some smaller topics to get us going. But as always, before we get going, today's podcast is not N-O-T, not brought to you by Celsius. However, I love this stuff. I think it's great. I don't know what's happening. So, today's podcast, the main topic du jour, I have a few, but the main topic is why therapy doesn't work. Now, this might sound pessimistic, but I actually have a very optimistic view that I'd like to discuss. But before we get to that main topic, I have a Nick Tabor post, for those of you who are familiar with him. And I always try to start with a softball post. And by the way, if you are new to this podcast and you're listening for the first time or watching for the first time, I try to live tweet whatever topics or content I'm discussing. And so you can follow me on Twitter. Hey, Phil. My handle on Twitter is at AlobhaPatrick, at ALOBHAPATRICK. That's where you can find me live tweeting. You can follow along. You can like, share, you can comment, you can cancel me, all these fun things on Twitter. So, before I get into the main topics, Nick Tabor's post, why therapy works, doesn't work, etc., I want to start with the softball post, which will at some point, I think, relate to why therapy doesn't work. But I want to start with this simpler, more important jumping off point. So let me just retweet this real quick. Again, my handle's at alobhapatrick on Twitter, at ALOBHAPATRICK. Okay. Okay. So the first thing I'd like to discuss today on the podcast is a post I made. This tweet was on May 30th, and I want to start with the basic premise that there are many misconceptions for people who are seeking out counseling, coaching, clinical psychology, psychiatry, that your professional that you're working with is somehow, a similar or homogenous kind of person, that all professionals, are similar kinds of people. But the truth of the matter is that your professionals are not similar kinds of people. In fact, there are very different kinds of personalities that end up in the world of therapy, counseling, coaching, psychiatry, and so on and so forth. And so now that I've said that little introduction, let me get to the actual post. So Seth Fowler, who I've followed on Twitter for some time, said, I had an interesting discussion with a group of therapists, more disagreement than I expected. Should every therapist be in therapy themselves? And my immediate response was to this, no. Example, let the personality disorder types of therapists be their unique messy selves, which can often help very specific types of people. So Seth's post was, should therapists be in therapy themselves, which is a very trendy topic in graduate psychology where I teach and things like that. So my answer to that is do therapy if you want to, because it could help you. However, there are many different types of creatures that become clinicians, psychiatrists, counselors, coaches, so on and so forth. And I do not believe that there is one universal way for people to improve themselves as professionals. I think professional consultation is an excellent choice, which I do for a living. I think supervision is also an excellent choice, which I do for a living for pre-licensed interns. I also think therapy is a really good choice for some people as well. I also think learning from your experiences on ordinary self-reflection is good experience. And then I think there are rare subgroups of professionals that exist that can help special groups of people. I think there are sometimes very ill people who become professionals. And these very ill types, usually personality disorder types, have lots of problems. They cause lots of problems. However, I think they also help some people. There's a niche of people they can serve. Sometimes other people with personality disorders. So I do not believe that you have to be somehow healed enough or something, or guru enough or whatever, to be a very successful clinician in terms of helping people. But I guess it also depends upon what you mean by helping people too, which is an entirely different conversation. So should all therapists be in therapy themselves? No, I don't think so. I've done my own work, and I think it's informed what I do professionally to some significant degree. And I don't think I would change that. That being said, I can see a case for a number of people to not do therapy. And I don't know that it would make them better if they did therapy. So I really think it depends upon what kind of differences are we trying to make in the lives of people we call clinicians. That's the question, is what marginal or noticeable difference would change? Hey, Seth, glad you're here. Thank you for coming and being the first grist for the mill here today as well. So I think it's really important, in my opinion, to be clear about what your real goal is. Because to me, the real goal is going to differ depending upon what kind of professional you are. So for instance, if you're one of those clinicians that doesn't do super deep things for a living, if you're kind of like a behaviorist of some kind, like an ABA person, you probably don't need much personal therapy because you're just kind of doing the simplest non-deep things with patients and their families. Like CBTI. I'm sure folks that do cognitive behavioral therapy for insomnia often don't talk about super deep things. It might be worth it. It might be worth it for you to be more aware of your countertransference and things like that. However, can you still help people if you're kind of a mess in some way? Absolutely. Do I recommend staying a mess in some way? Not generally, if you want more peace of mind in your life. However, some people are personality differenced enough, or even disordered, that they can't really achieve a certain amount of peace of mind. I don't know that that's really possible if you're built that way. No differently than if you have an IQ of 80, you're having a pretty limited life in some ways. So I would argue that certain people certainly do not need therapy. It wouldn't make them better at what they do. In fact, it's their illness, it's their differences, it's their screwed upness that makes them uniquely helpful, despite all the consequences that come with that. So it's a trade-off question. So thank you, Seth, for the grist for the mill from May 30th. I appreciate being able to talk about your post. And if you disagree with my hot take, feel free to tell me. So moving right along in the similar train of thought of does therapy work? How helpful is it? How not helpful is it? So on and so forth. I think there's a couple of Nick Tabor things I'd like to talk about. So what I would say is, before I even dig into Nick's post, I want to be extremely clear, very, very clear that it's complicated, but also there are some simple things we can take away from his post. So let me just retweet it real quick and we'll get going. And if you have not followed Nick Tabor on Twitter, his handle is at NICKTABER. Okay, so 4 hours ago, Nick Tabor, who is in the critical of psychiatry, psychology world, said, and this is one of two posts, so he talked about how mental health professionals who work with kids often try to make them compliant and essentially zombie slaves. I'm going to be a little dramatic. And he said, after they've gone through this mind-numbing experience of authoritarian therapy, then when these kids who went through this become young adults and die of suicide or drugs due to this abuse by professionals, it gets framed as, well, they were always struggling and we gave them the best possible care. So just to walk this out for everyone, because Nick has a particular bent on the problem of kids in therapy, which I spoke about a few weeks ago as well. So it's very often the case that when kids are acting up in school or at home, they are sent to a therapist or a school counselor, even worse. Excuse me. And so these school counselors who are not well trained at all don't understand the difference between situational distress, a crappy set of parents, and actual mental illness. Those three things can overlap, but those are not the same thing. And so Nick's general approach, I think, if I'm being fair, is that most kids who are sent to therapy because of school behavior or home behavior are basically being suppressed, subdued, in kind of this authoritarian, comply framework. I can agree with that in many ways. I also have some disagreements. And so his second post is, when these kids are basically beaten into submission after a number of years of being in the system as middle schoolers and teenagers and things like that, then they become adults, and some of them, he said, die by suicide or drugs due to the abuse of the system. It gets framed as, well, they were always struggling, right? And so what I would like to say about this, which will bleed into my main topic here, which is why therapy doesn't work, is it really depends upon what you mean by if therapy works or not. And so can it be the case that you can use the services of psychotherapy or counseling or whatever to help people become more pro-social? Of course you can. That being said, is that the goal of therapy? Often it isn't or shouldn't be. But I think Nick's point is that the system, the school therapy system, make kids submit and become normal factory machines, Henry Ford thing system, basically beats the life out of kids psychologically or in some cases physically. And so they will be so repressed or hate themselves so much because of the abuse they get in the system that they might die by suicide or accidentally overdose or on drugs or something. And it is common to hear professionals rationalize that, well, that person was sick and beyond help. And here, what I will say is, nobody is beyond help. I'm going to take a very controversial stance here. With the exception of like a brain tumor that you can't treat that's making you impulsive or something, no person is beyond help. Every person we interact with is certainly capable of being supported, guided, etc., in such a way that their life could get better. In my career, I've seen very, very ill people, very, very traumatized people, people beaten down by life, beaten down by jail, crappy parents, poverty, abuse, molestation. I've seen terrible things in my career. And I've seen so many people overcome these experiences, partially in part due to therapy. And what I would say is, no one is beyond help. And the idea that someone was just so sick they were unhelpable is bullshit. So if you're a professional who's like, oh, the poor kid was beyond help, that's not true. That's totally not true, in my opinion. I think that's a cop-out. That's an excuse. It's a justification. And that is different than saying someone is really suffering and it's going to take a lot of work to help them. Seth is in the chat here, says, I appreciate Nick's passion about wanting to help people not be trapped, but it seems that he thinks the entire system is just abuse. Yeah, I share a similar question about Nick, kind of like overgeneralizing a bit, which he admits to. Like, in my experiences with Nick on Twitter, he has always been very straightforward about the fact that he has a perspective because he's trying to call out a particular problem. And fair enough. I think everyone should be entitled to their perspective, no matter what, even if I disagree with it or think it's disgusting or bad or whatever. So I don't think his perspective is disgusting or bad. I think he is just, overgeneralizing, and I think he is trying to point out a particularly toxic and insidious problem. And so, do kids get abused by the system? Yes. Do mental health professionals, so-called, who work in schools or who work with kids or adolescents, abuse kids? Absolutely. I know plenty of cases where that has happened, and I have treated those people as young adults in my career. And it's sad because they tell you horror stories about being in, residential programs or school counseling sessions or whatever it is, and it's just tragic. And occasionally those people do die, and that is tragic in my opinion, and it's very sad. And there's nothing that I can do sometimes about those situations. I can think of 2 stories off the top of my head where somebody who left one of the treatment centers I was working in months later died due to accidental overdoses. And did those people need to die? Did they want to die? It's hard to say. It's very sad. However, I don't know what else I could have done, especially given that they were out of my care. And so it's one of those tragedies of people can be so badly abused. One of them in particular I'm thinking of was badly abused since he was a teenager by the system. Gay conversion camps and all this crap and just terrible stuff. And he was shamed and humiliated and defeated over and over again and objectified by the system. And so I know exactly what Nick is talking about. And what I will say is more could have been done to help these 2 young men who died in these examples I'm bringing up. No one needs to die. I don't want anyone to die, ever. And unfortunately, they do sometimes. Unfortunately, they hate themselves so much, they feel so hopeless and powerless that they kill themselves. Or sometimes people accidentally die because they overdose and all these things. So there's so much tragedy that happens because people are abused by the system. So I can relate to what Nick is saying. And the idea that they were beyond help is absolute horseshit, in my opinion. So what I will tell everyone is, if you feel like you are beyond help, you are not beyond help. So many people feel hopeless and helpless, and that is not true. It may take a long time. It may be extremely difficult to feel even 1% better, but it's very possible. Everyone that I have worked with who has been in miserable circumstances has found some way to feel better. even if it's temporary sometimes. So no one is hopeless. And anytime someone says, well, they were always struggling, we gave them the best care. No, you didn't. No, you certainly didn't. Almost no one who dies by suicide or of an accidental overdose is getting the best care. Sometimes they do in very rare circumstances. But the vast majority of times, kids that are stuck in the mental health system or abused by the system are not getting the best care because they're being abused. So, let's be clear about that. So, most kids don't even get good family therapy where the therapist tries to help the parents shut up and learn how to be better parents. So it's a question of, are we actually giving kids the care that they need? No, right? In many cases, kids in school therapy or counseling, God forbid counseling, I wish that profession would disappear in my opinion, but it's such a problem, all the ways in which kids don't get an accurate assessment and an appraisal by the systems. The systems are shallow. The systems are not deep. The systems are not thorough. The systems are let's get by because we're underfunded and not run well. They're run by people who are bureaucrats, not by people who are expert clinicians. So there's a lot of systemic problems, dear Nick, and I think we should talk about it more, in my opinion. Which brings me to the main topic of today. So, the main topic of today is one that is near and dear to my heart, which is, as a clinical supervisor, as a professor in graduate psychology, working with doctorate students and master's students, I care greatly about clinical work working, being effective. And so what I wanted to do today, and I hope that everyone's here who's watching and commenting and all this stuff will chime in, because I want to hear what you think too, genuinely. I want to talk about all the ways in which therapy cannot work, the ways in which therapy can fail. And then I want to end on a note of optimism that might sound weird. So that's the thing I want to kind of launch into here. Okay. So first and foremost, I'm going to list my top 10 reasons why I think therapy fails and then go through them a little bit, because I think that these top 10 reasons are the more common reasons why therapy fails. And if you have others you'd like to add to the list, please let me know. So the first reason that therapy fails is because there's a substantial and irreconcilable personality mismatch between the patient and the client or the therapist. The second reason is because the therapist is just flat out missing important dynamics, transference, countertransference, so on and so forth. The third reason that therapy fails is because of very poor informed consent, which I've spoken about many times in this podcast. The fourth reason that I think therapy fails is because there's insufficient hope in the relationship, which I will speak more about today too. A fifth reason that therapy fails is because there's a lack of agreeing on a shared goal that both parties are fully invested in, to the extent humanly possible. The sixth reason that therapy fails is the patient is lying to the therapist and the therapist is not catching it. The seventh reason that therapy often fails is because there's a rupture in the relationship and it's not either repaired or it's not repaired good enough in the relationship. An eighth reason why therapy often fails is finances. The person is not able to afford the relationship anymore, etc., etc. A ninth reason that therapy often fails is because of outside external events that cause the person to have to leave therapy, right? So like, my aunt in New York is dying and I can't see you anymore, something like that. And finally, the 10th reason that therapy does not work is because the patient is just not ready to change. So these are my top 10 reasons as to why therapy fails. Now, obviously, inherent in this particular hot take of mine is that you have to have a well-formed goal about what success actually means for therapy, right? So if success means I can cope better, these 10 reasons probably aren't going to get in the way. But if success means I feel more empowered, I grow, I overcome some narcissistic injuries or some attachment failures or whatever, deeper childhood analytic, blah, 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 then these 10 reasons are all potentially going to be a problem. And some of these overlap and they're related to each other. And so I fully acknowledge that, some of these are actually directly related to one another. But I want to go through these 10 things with just a little bit of time so that we can understand them better. And if you're out there and you're out there seeking therapy or counseling or couples therapy or coaching or whatever it is, doesn't matter what the format is, these 10 things I think are all valid experiences. And many of these things, if you remember the list of 10 things, many of these things have nothing to do with the patient. Many of these things are the therapist's responsibility, right? And so I want to go through these 10 things, and feel free to shout out in the chat, etc., as you see fit. If you want to leave a comment later on about something that didn't sit right with you or didn't make sense, let me know. So number one, the first thing I listed here is that there's a personality mismatch between the patient and the therapist. And the reason that I put this here is because, especially, it's become clear to me about myself that depending upon how you're built, right, which includes personality traits like openness and conscientiousness and narcissism and hysterics and obsessional and all these things, all these personality organization variables, trait openness, trait sensation seeking, all these things, your ability to relate to the other person and feel close to the other person is limited, right? And so if you're a therapist who's very narcissistically organized, you'd score very high, the 80th percentile in trait narcissism, there's a really good chance that you're going to be hard to work with the exception of maybe a more narrow band of people coming in for therapy and counseling. So very narcissistic therapists probably are great to work with for a couple of weeks or a couple of months, but long term, maybe not super easy in some cases. So I would estimate, and this is just me like pulling a number out of my butt that makes sense, that 70% of the time the personality mismatch is not a big deal and it is overcomable. But 30% of the time, that like outlier, second and third standard deviation, those types, I think it's impossible to reconcile. Darren in the chat here says, a lot of the work is done in the relationship. Absolutely. And so managing the relationship can be impossible in some cases if you are too personality differenced, in my opinion. Seth also said here, which I will add to my list. Here's what he said in the chat here. I've had multiple clients concerned about political beliefs in the intake session, wanting to make sure I wasn't of a certain political sway. I found it interesting that it's been such a significant fear. And I'll add that to the list, and I'll talk about some solutions to that too. So again, back to number one, personality mismatch. I'd say 70% of the time, the mismatch, the discrepancy between how you're built and how the patient's built is very, very manageable. It just requires a skilled therapist paying close attention to transference issues, countertransference issues, and other dynamics in the relationship, ruptures, etc., and doing your best to manage the relationship. As Darren said, a lot of the work is done in the relationship. Number two, which kind of falls in line with number one to some degree, is therapy can fail because the person that the professional, so to speak, that you paid money for is actually not paying good enough attention. They're missing things. Right? So something that happens in therapy all the time when patients feel unsupported or unseen, this is typically how it's reported, right? It's like, I don't think my therapist was getting me. I didn't feel like I was going anywhere. They'll say stuff like that, right? And so that means the therapist is missing something, right? So if your patient is saying, if you're out there and you're a patient and you're feeling like, I don't know if my therapist gets me, or I don't know if we're going anywhere, like that means your therapist is missing something, in my opinion. They're missing a transference dynamic. They're missing a countertransference dynamic that's interfering with having a better relationship with you. Maybe there's a hidden belief or motivation on one or both parties' parts that's not being discussed. Because, for instance, just to name a very simple thing, common, I think, thing that happens all the time is it's very common in therapy to be talking about some deeply important thing like self-worth or feeling important or romantic relationship stuff or whatever it is, or politics. And people have drastic insecurities that they superficially understand. And because they superficially understand these insecurities, a less skilled therapist might understand the situation incorrectly. So if you're a less skilled therapist, you might take that superficial thing the patient says about their insecurities and take it for granted and maybe go too fast and go too deep, like make some interpretations and some stuff like that before the patient can actually tolerate it, and that can cause a rupture. So if you have a patient who's sitting across from you and talking about some seemingly deep insecurities and you're trying to interpret stuff to them, but they can't handle it yet, that is you missing something as a professional, and you're probably harming them without knowing that you're harming them. It's causing a rupture that they might not be even like fully conscious of. They just might feel bad and not be able to understand it with you. So that's number 2. Therapists missing things. Therapists miss things all the time. That happens. But missing things isn't in and of itself catastrophic. It's missing things and not taking time to figure out what you're missing. That is the problem. Okay. Number 3, one of the topics that I harp about on this podcast, so I'm not going to belabor it. There's so many episodes where I explain in full detail what informed consent actually is. But if you don't have appropriate informed consent, then therapy is going to fail. Because if you are not clearly explaining what you see the problem to be, and if the patient is not agreeing with your formulation, then you're already not on the same page. And if you're not on the same page, you can't have a good relationship. So you have to be on the same page. You have to agree, even tentatively, to what you think is going on, how you think you should handle it, what you think might work and not work, what are benchmarks of progress, and how to handle problems, ruptures. If you can't do the informed consent thing correctly, especially in an ongoing way, therapy will fail. Think of it like relationship maintenance. Number 4, this one is actually extremely important. And I was talking with one of my supervisees about this yesterday. It's extremely important. So, number 4, if you remember my original list, is lack of hope. So it's very often the case that therapy fails because the patient or the therapist or both have slipped into some kind of cynicism or pessimism. It is my belief that cynicism and pessimism is for cowards, number 1. So I have a strong bias, extremely strong bias about this. And maybe I'm wrong. And so if you disagree with me, feel free to let me know. I just think that it's absolute cowardice if you believe that, the pessimistic attitude or approach is the correct one. I think if you are lacking in hope as a professional, then what's happening is you are not looking at the data clearly, number 1. You have a bias that pushes you to not look at the data clearly. Now, there's a difference between talking about a difficult moment or what might make it hard to complete treatment successfully, etc., versus being completely pessimistic or lacking in hope. So to me, lacking in hope is especially toxic and problematic in therapy because it will work if you are both committed to it working. So to me, it is ethically incumbent upon the therapist, the clinician, the counselor, the psychiatrist to have hope and to hold hope for the relationship, which is different than being naive and stupid. But if you don't have any hope, if you're not able to help the person find whatever hope exists inside of them naturally, then you are a failure as a therapist, and the therapy will fail because hope is essential to change, essentially. And I think that hope is extremely important because I think hope is the accurate read of the data. I think most people on the planet should have hope about the possibility of their lives getting better, because most people live in circumstances where it can get better. It might be exceedingly difficult for many people in many countries, situations, lifestyles, families, etc., but it is possible. And living pessimistically or cynically is cowardice, in my opinion. So if you're lacking in hope, that is a you problem as a professional, and you should get a handle on that shit ASAP. And as a supervisor, I will not tolerate it. You're allowed to be appropriately skeptical of what's happening in the therapy relationship as a professional. But skepticism is not the same thing as lacking in hope, right? So in the chat here is Sarah, who says, hey, Dr. Lockwood, is it all on the clinician? What if the client is unwilling to change their priorities or ways of thinking? Is it all on the clinician then? So that's a tough question to answer, Sarah. What I would say, generally speaking, is that 9 times out of 10, if the patient is unwilling in some way, there's usually some kind of dynamic, often relatively obvious, sometimes not, that can be addressed in the relationship, right? And so I'll give you an example of something I have observed in my career. If the patient is sitting across from you and they're unwilling, and this is something I've seen in drug rehabs a lot, people don't want to get sober for dozens of reasons, often good reasons and sometimes stupid reasons. But people don't want to get sober because they're terrified of living differently. You know, for many people in drug rehabs, they have become institutionalized. They see themselves only as patients, kind of like people in prisons only become prisoners and criminals. And so if you've identified with or adopted an institutionalized identity because of the circumstances and your illness is hard to treat, then you have a good reason to not want to change ever again, because you're in a system that makes sense to you, and moving out of that system is terrifying for people. So identifying the dynamics, identifying whatever the unwillingness is and talking about it is where the work is, right? And I'm not saying it will work out perfectly, Sarah. That's not what I'm saying. What I'm saying is, if you cannot at least have a conversation about the unwillingness, then you've failed your patient, basically. And so if you have to spend 5 sessions talking about the unwillingness, then spend 5 sessions. I don't think it would take 5 sessions, but if you have to, do that, you know? So for me, I think the issue becomes, what is the dynamic that's happening between yourself and the patient such that the person is remaining unwilling? You know, we have decades of research using solution-focused therapy and motivational interviewing that can move people along the stages of change. Excuse me. And so it's to me, it's absurd that people would stay unwilling forever. Like that would be a permanent state of being. Now, when I get back to number 10, which is not ready yet, I'll spend more time talking about what you're saying, Sarah. Number 5, difficulty creating a shared goal, which can also relate to what Sarah asked as well. So this is, I think, half on the therapist and half on the patient throughout the course of therapy. Agreeing to a shared goal is extremely important. And many times therapists want something the patient is not willing to do, as Sarah said. And sometimes therapists, counselors, psychiatrists have their own psychological baggage that makes them want something for the patient that the patient does not want for themselves. So if a therapist, for instance, because I've talked to some of my supervisees about this, but if a therapist wants them to be less anxious because the therapist themselves had an anxiety problem, then guess what? You're probably going to emphasize the anxiety that the patient has when that might not be their primary goal. So you're focused on something they don't want to be focused on, which means it's not going to work, right? And that happens all the time in therapy, where the therapist, the clinician, the psychiatrist, psychologist, whatever degree level, wants something that the patient doesn't want. They're not agreeing on the goal, which means it can't work. It might work for a couple of months, but it will eventually burn out. The patient will be like, nope, I'm not interested at some point. So you have to agree to a shared goal. Number 6, the patient is lying. This might also relate to what you asked, Sarah. So patients lie all the time. I'm going to say this very, very straightforwardly. And this might sound controversial, but in my opinion, it's like saying the sky is blue. So patients will come to therapy all the time and lie to their professional. And that's not weird. And the reason that's not weird is because therapy is a very strange and uncomfortable and vulnerable experience for a lot of people. It is very weird to talk to some random stranger that maybe you've only known for a month or 3 months or whatever. This is a person you've never maybe even met in real life because it's all telehealth or whatever. So talking to some random stranger who supposedly is a professional, who supposedly is maybe even an expert in something or whatever, is weird. So deception in the therapy relationship is not uncommon. Now, do patients lie about big things or little things? Probably both. Sometimes they lie very little and sometimes they lie a lot. And the other interesting thing that happens in therapy is the therapist will lie to the patient. They'll try to tell a story to make themselves idealizable to the patient. They'll tell a story to make themselves, especially good, especially calm, especially whatever. So lying happens in therapy, and I never recommend it. I think it is toxic, and it is the death of the relationship, because the more deception, whether it's little white lies or whatever, the more likely it is for the relationship to not work. And so don't lie to your patients if you're a therapist, number one. If you're a patient, if you are seeking out counseling, coaching, couples therapy, whatever it is, please don't lie in therapy. Do your best to tell the truth and sit in the discomfort and the uncertainty and the vulnerability of telling the whole truth, because there's a really good chance it'll actually be better for you. Though I imagine Nick Tabor would have a different opinion. Number 7, this is very common as well. Number 7, ruptures. So ruptures happen in all therapy relationships. Unless you meet somebody one time and only one time, ruptures happen in all therapy relationships. Sometimes the ruptures are tiny. You could call them misattunements, where we're not quite on the same page, or I kind of don't get you. And sometimes they're big, like the therapist said something that hurt you, or the therapist said something that, brought out a vulnerability you're not ready to deal with yet, or whatever it is. So when there's a rupture, especially a sizable rupture, or a series of small ruptures that haven't been addressed, then it's very important to address them. Because if there are like dozens and dozens of small ruptures that have never been addressed, or if there's like a couple of big ruptures, or even one big rupture that hasn't been either appropriately repaired or fully repaired, then that can sabotage the relationship. And I would say, back to Sarah's question, who is responsible? Is it the patient's responsibility? Is it the therapist's responsibility? I think if you're an ethical clinician, when you're doing informed consent, you should say something to the effect of, all therapy is a professional relationship of whatever kind. And in these professional relationships, I will make mistakes. We will make mistakes together. And that might cause what I would call a rupture, where we're uncertain about each other, or we have feelings. And so I think it is best practices to talk about ruptures when they happen so we can address them and repair them. I think if you're an ethical therapist, you'll say something like that at the beginning of all therapy. Now, does everyone do that? No. Do most people do that? No. Should they? Yes. So is it more on the therapist to own and describe and discuss what Sarah might describe as unwillingness, which is actually just a rupture that hasn't been addressed, for example? Yes, it's on the therapist, in my opinion, because we are paid to be the adults in the room for the person who is not ready to be an adult yet about these topics. Number 8 is finances. So it's unfortunately the case that because people live in sometimes financially very tenuous circumstances, that they will not be able to afford ongoing therapy, especially if you have like a cash practice. And so those financial issues, sometimes the therapist can adjust and do like a cut rate or something like that for a period of time or whatever, or take a break temporarily. So taking a break temporarily is not failure, but finances are a real problem, and some people literally can't afford therapy. It happens. And so that is like no one's fault. Essentially, that doesn't mean something bad happened between yourself and the patient. Number 9, big events outside of therapy. So major crises. Aunt Sally is dying in New York and I have to leave California to go to New York and you can't practice outside the state of California kind of thing. Or the person has to get a second job and they don't have the time anymore. That has nothing to do with the quality of the relationship or transference or countertransference or whatever it is. Sometimes life stuff happens and it's not anyone's fault. And reading into it is just analytic bullshit. Number 10, finally, the patient is not ready. So this happens more often than people would like to admit. And it's very tempting to psychoanalyze and read deeply into it, but sometimes people aren't ready. It is very often the case, in my opinion, that people will want to start therapy. And so what they'll do is they'll probably find a therapist who's like your paid best friend. And they have a paid best friend therapist. And that paid best friend is trying to do the paid best friend thing, which is like chat about the weather and their dogs and their cats and all this stuff, but not really talk about their relationship or anything else. So paid best friend therapy is just another way for people to spend money and pseudo engage in trying to change, but not actually change. And paid best friend therapy is very common in today's society, unfortunately. Another thing that happens is people just kind of focus on coping skills and brief short-term change, which is fine. Short-term change is great because some people only are ready or capable of short-term change. Some people only care about short-term change, and it's not my job to make you care about something that you don't care about, right? So not everyone is super ready to deal with, quote unquote, all the things that are going on in their life. And that is not on the therapist. If you're an ethical practitioner, you can use solution-focused therapy and motivational interviewing and good transference discussion and counter-transference discussion as needed. But that doesn't mean that everyone who comes to therapy needs to talk about super deep things or is ready to. So some people, if they talked about deeper developmental things, it would absolutely benefit them in the here and now and ongoing. Other people, it wouldn't actually magically make the here and now much better. So the idea that everyone who comes to therapy has to have some deep and profound experience is absurd. And some people are just not ready to do more than some of the easier things, like learning some coping skills and, getting their sleep back in line and eating better and asserting themselves better. Like, some people just don't need that, and some people just aren't ready for that. And nobody has failed if the patient just isn't ready. So back to Sarah's question, is it all on the clinician? No. The last 3 examples, 8, 9, and 10, are nobody's fault, basically. And so I have 7 reasons why therapy fails. 1 of them really is a patient problem. 6 of them are really on the clinician. And then 3 of them are nobody's fault, in my opinion. So this is just my list of 10. That doesn't mean this is the complete list. If you have other ideas why therapy fails, let me know. But I think it's important to be clear that, if you're trying to change, if you're trying to eat better, sleep better, whatever it is, the sabotage that can happen, especially if you have a coach, personal trainer, dietitian, therapist, counselor, whatever it is, excuse me, literally speaking, it's important to be very, very clear that not everything will work, because that doesn't mean everyone's super ready. Just because you hire a dietitian, that doesn't mean you're actually ready to change your diet. Just because you hire a personal trainer, that doesn't mean you're actually ready to be in better shape or to treat your body with more respect, which is how I see it. Sarah says, how do you define deeper things in this context? Well, the classic psychodynamic, psychoanalytic deeper things like childhood issues and narcissistic injuries and attachment ruptures and, self-concept issues, developmental psychology issues that aren't purely coping skills and more superficial things that people talk about in other types of therapy. So deeper things are not always important, which, by the way, not everyone has to be super healed to have a really good life, by the way. If you were yelled at as a kid, if you were hit as a kid, you don't have to perfectly resolve that to live a good life. It might help to resolve those things and their impact on you, But most people don't actually have to have some perfect resolution of their childhood stuff or whatever to actually live a great life. You know? Because everyone's goals are different. And everyone needs different things. And like right now, you might need something more superficial or more like cognitive or more like behavior change oriented, just to like get in the habit of working on yourself before you deal with deeper self-respect, do I deserve love kinds of stuff, if that makes sense. Also, a lot of people that come to therapy aren't that dramatically injured, right? This idea that everyone who comes to therapy has serious personality organization issues or something is not true. You know, that's sometimes true, but a lot of people come to therapy because they just like, they suck at asserting themselves. And sometimes they suck at asserting themselves because their dad yelled at them or their mom abused them or whatever it is, you know. Yeah, 48 minutes and you finally got the burp you were hoping for. I'm glad. So these are my 10 reasons why therapy often fails. I hope they make sense because, you know, genuinely speaking, I want to share this with you all so that you can identify them if they're happening in your counseling session, in your couples therapy, in your family therapy, in your individual therapy, in your psychiatry sessions. What if you're in rehab, if you're in IOP, whatever, wherever you are right now, if you're identifying any of these 10 things, then I hope you get a chance to speak up to your professionals about it. And if you're out there and you're listening and you're a professional, I genuinely hope that you can try to recognize any of these 10 things, especially the first 7, because the first 7 are more so on you as the professional. So the reason I say I am optimistic about mental health in the country, in most industrialized nations, is because there's so many people out there that do pretty good work. Different kinds of people, cognitive therapists, analytic types, psychodynamic types, family therapists, whatever. There's so many opportunities for people to get better that I think we live in the best possible time to work on yourself. If you need to heal something, heal something. If you're looking to grow in some way, you can grow in some way. There's no better opportunity in history, in my opinion, to work on yourself. If you're interested in working on yourself, you know, like as I've gotten older, I care more about habits than I care about psychodynamic things because I've kind of done my work on that stuff and I get it and I see it. But also, it's easier to start doing the habit thing. And then once you're more in the habits, you can kind of look at the deeper things as they relate. It's easier for people. I want to kind of ease people into the process. So I believe very firmly that here we are in 2026, and it's never been better for people to find professionals. Like, I'm encouraged by the people that I see on Twitter, for instance. As much as Twitter is a cesspool of mental illness and people who look mentally ill, especially in the profession, I'm actually encouraged by those people because, genuinely speaking, there are more opportunities to find your person. There are more opportunities than ever to find people to help you. And if you're in some kind of despair, you don't have to be alone anymore. And as much as people shit on, you know, the telehealth platforms like Rula or BetterHelp or Talkspace or whatever it is, thank God these things exist because some people are terrified of going to see someone in person or have no capacity to do cash therapy, so they have to use insurance. So thank God there's more availability than ever for people to get some kind of help, in my opinion at least. So I'm actually very optimistic because these 10 things that I just listed that I think are the most common reasons, all 10 of these reasons are overcomable in time. So I think that if you really want to change and you find a therapist you're willing to work with or a counselor or a clinician or whatever it is, provided they're not doing something absolutely disgusting like trying to sleep with you or cheat you financially or something, you can figure it out. You can work through it most of the time, in my opinion. And so that leaves me feeling very optimistic, despite the fact that the general topic is kind of negative, so to speak. So I hope that makes sense to everyone. And I would really love to hear any other feedback from anyone else in the chat here, because maybe I'm missing a big reason why people fail in therapy. you know. So I'll give it just a break. And if you want to chime in, feel free to chime in. I have another post that I do want to talk about, so I'm going to find it real quick while you're, yeah. Yeah. No comments yet. So what I'll do is I'll talk about this post that I've wanted to talk about for a little bit now. Okay. So this might seem Sarah says, what about unhealthy attachment? Been seeing that on the media lately. Yeah, I mean, unhealthy attachment is kind of like a, I don't know. The unhealthy or insecure attachment styles, like that's a trendy topic, but I don't know that it's as big a deal as people make it per se. Especially because attachment is not really it's not a variable that you can super easily adjust in therapy, comparatively speaking. So I don't know. So I want to end with one of my buddy Ed's posts. So Dr. Edward Perrin, psychologist on Twitter, posted this a while ago. I'm just going to retweet it real quick. Yeah, I think attachment becomes a focus because people like easy concepts, but I think that, we can become dependent upon our clinicians. And so, some people are dependent in their personality organization. And I think that the attachment you have to your therapist is important, but I think that, at least my opinion, which is the controversial one for the analytic types, is I think that if you become too dependent on your therapist, you're probably playing out some wish on the therapist part, some narcissistic, voyeuristic wish of the therapist, in my opinion. Because the therapist likes power and likes people to be dependent upon them. Whereas I think my approach is more balanced, which is I think some degree of dependency is necessary to be vulnerable, but it's important. So Phil said, speaking to the thing I just retweeted, which I think is extremely important. So I want to lead people on this thought process because it speaks to what Sarah's asking about too. Healing, whatever healing is for you, whether it's trauma or shame or attachment stuff or whatever it is, healing is not when your pain stops, because pain and memory doesn't magically go away with good therapy. Healing is when your behavior patterns change. It's when the patterns stop. So when the behavior stops, that's when you've started to heal. So as the behavior happens less, you've healed more. So the more the behavior stops, per se, the more you've healed, right? And so that is, to me, one of the most important tweets Ed has ever sent out, because it's the truth. Whether you're a psychoanalyst, a behaviorist, you like ACT, CBT, DBT, whatever it is, you've started to heal when the behavior has started to decrease in frequency, right? So if you've got all sorts of mom issues or all sorts of dad issues, and you're taking whatever those issues are out on your therapist or out on your partner or whatever it is, when those behaviors stop, that's when you've started to heal. Because you can't really suppress deeper stuff for very long. So shout out to Ed. I always keep this bookmarked, and I always like to talk about it once in a while because I think it's the correct attitude about healing specifically, in my opinion at least. So, and I think without further delay, I think this is the end of today's podcast. So I very much appreciate everyone who decided to come out today and chat in today's podcast. I really appreciate you. And I really hope that, if you're out there and you're struggling with your therapeutic relationship, so if you're listening to this and you're a patient, if you're a client in therapy, or if your family member is in therapy, I encourage you to look out for these 10 red flags, because these 10 kind of sabotage experiences are common. I don't think they're inherently malicious or evil or something like that. I think that because the tool of therapy is the person, that's what will happen, is we will sometimes fail because we're not paying attention to things that matter. So please look out for these signs and symptoms of therapy starting to fail. And thank you for being here. Please like, share, and subscribe if you don't mind, and kind of support the psychology checkup and help me get the word out so we can help more people get the most out of their mental health professionals that they're currently seeking. And without further delay, I'd like to end today's podcast with a joke. And happy Pride, by the way. So I once had this patient who was a young gay man, and he was having pretty typical young gay man problems. Some self-doubt, difficult time finding someone to date, sex issues, some drug misuse, things like that. So kind of a typical young gay mess, as it were. And so we worked together for some time. Nice kid. And, you know, a lot of his self-esteem was tied up in his dating life and his sex life. We talked about all the delayed adolescence stuff, which go see my YouTube video on delayed adolescence if you're LGBT. But anyways, we talked about, you know, all the kind of ways in which he was struggling to kind of feel important in relationships. And so we spent some pretty serious time focused on how to help him feel more authentically important and have an integrated, you know, LGBT regular person identity, essentially. Because one of my goals for everyone who asks for it is to help them feel more integrated. And, you know, we spent probably 3 or 4 months together. And at the end of that 4th month, he was back on the dating apps. And if you don't know, if you're new to the LGBT scene, there are lots of different, you know, hookup apps and dating apps. And, you know, there's apps like Grindr, which is mostly a sex app, and Sniffies and Scruff. And what else is there? There's a bunch of them. Anyway, so I think he was on an app called Scruff, and he found someone that he liked. And, they were sexually compatible and all this stuff. And, you know, the last couple of weeks of our therapy, as he started to feel more, you know, empowered and all this stuff, he starts going on dates with this guy. And apparently the dates are going well and they get along. They have some shared interests, shared principles, goals, politics, all this stuff. What I would say is that it was a very unique relationship because apparently this young man that I was treating had a kink called pup play, which is where you dress up like a dog or whatever. Not my thing, but I get it. Whatever. You know, God bless, be happy. And so apparently the dude he was dating from this app called Scruff also had this pup play kink. And he came back for our second to last session. And he's like, I think I've met the one, because we both have this, you know, shared kink about pup play and all this stuff. And I'm really excited. I feel really good about the work we've done. I feel like I feel like I found someone that works for me and we're similar enough. And I feel like giving it a try. And I don't know, I feel amazing. And I said, woof. All right. Have a good rest of your Saturday. Take good care of yourselves. Have good food. Have good sex. Have good fun with your friends. I will see you